Welcome to the Mama Fit podcast. In this episode, we're going to be talking all about pushing and how to know that it's time to start pushing. Pushing is definitely one of those things that a lot of folks have a little bit more anxiety about. Like, we don't want to tear. We've never experienced before.
Don't want to push for 7 hours.
No, we don't want to push for 7 hours. So we're going to talk about how you can know that it's time to push by comparing the fetal ejection reflex, which is spontaneous bearing down, versus laboring down and waiting to push. Welcome to the Mama Stay Fit podcast. This is Gina, perinatal fitness trainer and birth doula.
And I'm Roxanne, labor and delivery nurse and student midwife.
And this is the Mama Stay Fit podcast, where we empower you on your prenatal fitness, birth, and postpartum return to fitness journey.
Our podcast shares how to move throughout your pregnancy to stay strong and comfortable, because pain is not a requirement of pregnancy. Understand the science of birth and how to approach recovery after birth.
We share our personal experience as mothers navigating this stage in our lives, plus our professional expertise as birth workers and fitness professionals.
Our goal is to help you feel confident as you navigate the perinatal timeframe for an empowering pregnancy, positive birth, and postpartum journey.
We are glad to have you with us on this journey and that you have chosen us to support you. Welcome to the Mama Fit podcast. We're going to be talking all about pushing in this episode, specifically comparing how to know when to start pushing with the fetal ejection reflex, where you're typically unmedicated, you don't have an epidural, versus laboring down, or should you immediately start pushing once you're 10 centimeters. So we're going to talk all about kind of the initiation of pushing in this episode. So first, let's break down what are the different ways that you can begin pushing. The first one is going to be the fetal ejection reflex, which is your body is just, you're along for the ride and your body is pushing your baby out for you. This is usually related to the fundus being fairly thick and it's starting to push down on your baby. And the fundus is the top part of your uterus that during labor gets thicker throughout all your contractions. Your uterus is kind of pulling up into that muscle up there. The muscle fibers up there run vertically, so when they contract, they push down. And when that gets thick enough, it just pushes your baby out for you. There's really no effort on your part. You are just along for the ride, and there's some pros and cons to this as well. The next one is going to be just pushing once you're 10 centimeters. So this is typically going to be more if you have like an epidural. Your provider or your nurse checks you, and they're like, oh, you're 10 centimeters. Let's go. And you could just start immediately pushing then. And so that would be the way to know that it's time to start pushing. The next one is going to be if your provider checks you and you're 10 centimeters, but maybe your baby's still really high in your pelvis. So you do have the option to labor down or wait. But we'll kind of talk about the controversy with laboring down and weighing the risks versus the benefits and what the current guidance is so that you can make an informed decision on what you want to do during your own birth. So you can either just start pushing whenever your body tells you to start pushing, or you can start pushing when you feel like pushing once you're 10 centimeters, either right away or waiting a little bit. And we'll break that all down in this episode. So first, let's start with the fetal ejection reflex, known as spontaneous bearing down, as I like to graphically describe as vomiting out of your vagina. So there is nothing that you are going to do to stop this. And I have found that the fetal ejection reflex can sometimes start before you're fully dilated, like maybe you're like 8 centimeters. If you are less than, I would say, like 7 or 8 centimeters, it could be due to baby's position, and we don't really want to be pushing at that point. So maybe your baby's head is like OP or their back is to your back. This could sometimes cause like that early urge to push. If that's the case, I would do like an inversion and see if we can kind of adjust baby's position, because we don't want to be pushing when we're like 5 centimeters by any means. But if you're at least like 7, 8 centimeters and you're feeling this urge to push, it's typically the rest of the cervix is probably going to melt away within a few contractions. Signs to look for that maybe the cervix is not moving out of the way. If you feel like a pinching sensation, if it's like kind of painful, like usually like a little bit more towards the front, or if things just don't feel like they're progressing, those can all be signs that like maybe we're not quite at that point to push yet, and you might want some more support from your provider or from your nurse to kind of see what is going on there. What's your experience with the fetal ejection reflex with like dilation? The fetal ejection reflex, I find that if someone has that like strong, uncontrollable urge to bear down with fetal ejection reflex, the dilation, either they're going to just quickly dilate and the baby is going to be born, or it might not be like a true fetal ejection reflex. So they might have increased pressure that they think that they feel this pressure, so I need to bear down, but it could just be a change in sensation. Like they think that they're spontaneously bearing down because they have this increased pressure, but then we check them and they're only 5 centimeters or 6 centimeters. And that's usually, again, due to the position of their baby. And once we reposition their baby into a more optimal position for their bodies, their urge to push changes and they're like, oh no, now I'm pushing. And because it is a very different sensation between the two, with the fetal ejection reflex, like a true one, like there's nothing stopping it. Like Gina was saying, vomiting out of your vagina, you can't stop it, even if you wanted to. Whereas some people do mistake just a change in sensation that they're feeling because their baby is lower, but it's not time yet to push. They think because of this pressure, they think it's time to push. So then they start bearing down, but it's due to how baby is coming in their pelvis. So there is like some misconception of like, if I feel this increased pressure, it's time to push versus like you can breathe through it and stop it. Probably not the fetal ejection reflex. If you can't breathe through it and to stop it, it's probably the fetal ejection reflex. I feel like there's a difference between the two as well. Like, I think it's hard to know what that difference is when you have never gone through it before. But for me as like a doula, when I'm watching somebody, I can tell the difference between like that baby is about to be born versus are you feeling some pressure? Like what's
Yeah.
So there's a really big difference. And it's
The noises
completely involuntary. Like you were just along for that ride. And now the fetal ejection reflex, typically I see only with somebody who is unmedicated, so they don't have an epidural, or they're progressing really fast with an epidural. Like it's usually one of those two. But if you've had an epidural for a while, I would say you're probably not going to experience the fetal ejection reflex. And it's not 100% with unmedicated birth either. Like you could be unmedicated and not experience it also. And so completely relying on the fetal ejection reflex as your cue to start pushing when you're unmedicated may not be like 100% appropriate of a plan as well. And so this is where like communicating with your provider about what's going on during your labor and kind of assessing things as needed can be really helpful to figure out like when should I start pushing. I think with the fetal ejection reflex and an epidural though, when you are unmedicated, it's not just this crazy increased pressure, your body's uncontrollably bearing down, but you also still feel all of those sensations in your body with fetal ejection reflex that it can kind of push you over the edge stress hormone wise. And you're just, again, holding on for dear life, trying to cope with what's happening within your body and all the sensations that are happening within your body. Whereas with an epidural, you don't have that sensation that feels very overwhelming. You might feel like, oh, hey, like it feels like my body is pushing, but I'm not. Like I'm not trying to push. Usually this response is, it feels like my belly is like pushing my baby out, but like I'm not doing it. I promise I'm not doing anything. And I'm like, it's fine. Like your body is pushing your baby out and that's what we want. You're likely experiencing the fetal ejection reflex because I can see your baby is like crowning and you're not doing anything.
Your baby has been born.
We're going to call the provider in and they're like, I swear I'm not pushing. And I'm like, it's okay. This is what you're experiencing. Because they're like, I don't want to get in trouble for pushing my baby out. And I'm like, it just happens. You can't control it. It's not like you're like, fetal ejection reflex button. Yeah, there's no like conscious start to it. It's a spontaneous thing. So for me, with my first labor, I had an epidural, so I did not feel anything.
Oh, no,
it was a very strong.
You had no fetal ejection reflex.
I had no sensation at all. It was a very strong epidural. We'll talk about laboring down and stuff we'll talk about my epidural experience when we get to laboring down. For my next 3, though, they were unmedicated births. And I was in a very supportive environment, which I think is a big factor in whether or not you experience the fetal ejection reflex. If you're feeling very unsafe in your environment or there's just like a lot going on and it's very distracting, I definitely find that the urge to push is maybe not as strong for some folks. And so with my next 3 births, I was in a very supportive environment. I felt very safe in my environment, very supportive. It was like quiet voices, dim light. The first time that I experienced the fetal ejection reflex was with my second birth, and it was completely out of body. I was like witnessing myself from outside my body. Like I just had no control
on the ceiling.
What was happening. In the moment, I wasn't like scared. I just kind of was like, whatever, like I guess this means my baby's coming. But after the fact, when I was reflecting on it, it was kind of scary. I was like, that was really intense and like super out of body. Like, oh my God, like that was a lot. Like, huh. But it wasn't scary in the moment for me, but I know that it can be scary for people in the moment because it's just like really strong urge. There's so much pressure. You can't control what's happening. It would be like, again, it's like vomiting. Like nobody likes vomiting. I don't like vomiting. And so when I was preparing for my third birth, I was really nervous about the pushing phase because the pushing phase was really intense and it was such an out-of-body experience that I was kind of scared for it. And so during my third labor, which was my second unmedicated birth, I was kind of anticipating it and kind of nervous for it. And I think maybe like stalled my labor towards the very end when my body was ready to start pushing. And I was kind of like, I just need a moment to like mentally prepare that this is about to happen. And then went through the pushing, same thing, really out-of-body experience. Felt like I was witnessing it from outside my body. It was very strong, very intense. The baby was born really fast. And like, it was just like this relief once she came out. But both times I felt like I needed like a moment to like recover. It wasn't like immediate like angels singing, like I'm like nuzzling to my baby. It was like about 30 seconds of just like, oh my God, okay, it's over. And so then for my fourth birth, which was my third unmedicated birth, I was just anticipating that it was going to be just as intense and like out of body again. I was like, there's just no way that I'm ever going to find like a moment of peace during this. Like they're just all going to be insane. And this was the first time that I actually was able to kind of collect myself during it and like come back into control with the urges. This labor was also much faster. I felt like I was just in a better mindset to like surrender to the experience for this labor. But I was able to find that moment of like control this time, which was like a very unique experience for me. But I still needed like 30 seconds to like recover after she was born before I was like, okay, we're good. We're all good. Like, hey baby, what's up? So yeah, what was your experience with the fetal ejection reflex? Because yours looks different than mine.
To be fair, I don't know if I necessarily experienced like fetal ejection reflex with like my births in the same way that you did, because with my first, Lily, I felt the urge to push, but I don't think it was the fetal ejection reflex because I had to add to all of my pushes. Like if I didn't push, nothing would have happened. If I didn't add to the push.
I was not doing anything.
I had the urge to push, and when I bared down, then it felt better. But if I didn't, then it was just like a lot of pressure in my butt. And with Colin, I felt the urge to push earlier on, but baby, like he was still pretty high the entire time until I stood up, my water broke, and then he just literally shot through the pelvis and was born in the tub. And so the fetal ejection reflex was fairly short in his, that I was like, oh, that was it.
Yeah, you look way more in control and like serene during yours.
But then Jones, which again, I don't know if it would be the fetal ejection reflex for sure, because I, again, had to add to all of those pushes. Like my body was bearing down, and if I didn't like add to it, it was just like very overwhelming. But like my body wasn't pushing her out. I had to. But maybe it's because both of those babies were 8.5 pounds. So I had to make more room.
Yeah, maybe.
I had to add to it because there's a lot more room that needed to be made. So I don't know if I've experienced like the fetal ejection reflex in the same way that you have, except maybe Colin's birth. And if that was the fetal ejection reflex, like, oh, that's not too bad. But it is, pushing in general is very overwhelming for me. I think I experience a different reflex though. So I think what I experienced when I was pushing is more similar to what's called the Ferguson reflex versus the FERS.
Or the fetal ejection reflex. So before we move on to the Ferguson reflex, which is really similar to the fetal ejection reflex, with both of them you're feeling this urge to push. With the fetal ejection reflex, there is pretty much no effort on your part. I mean, there's exertion. It's mentally challenging. There's physically challenging, but you're not adding to those pushes. With the fetal ejection reflex, like I said, it's like vomiting out of your vagina. There's nothing that you're going to do that's going to stop it. And I typically find this more common if you're unmedicated and you're in an environment that you feel very supportive in. It's like dim lights, quiet voices. There's not a lot going on. I tend to see that this reflex is a lot stronger versus if you're in a room that's really bright lights, there's lots of people coming in and out, it can be really distracting and you may not experience like a super strong urge to push in those situations. I also see it with folks that have an epidural that just got it and they're progressing really fast. So let's say they were in transition, their baby was coming and they're like, no, I would like an epidural.
Get that epidural nap.
They get the epidural and then their baby's falling out of their bodies. Those folks I sometimes will also see have the fetal ejection reflex because it was already happening when they got an epidural. But again, more commonly if you are unmedicated. Now, we can't consciously initiate the fetal ejection reflex. And so relying on it solely as your reason to start pushing may not be something that you want to do. Like if it happens, which it likely will if you're in a supportive environment, that's awesome. Just go with the flow. If you never get it, but you're sitting there at 10 centimeters for a period of time, it may be time to start pushing, which we'll kind of talk about when we get to active pushing later on. I will say one thing that I sometimes see happen if somebody does have that spontaneous urge to push is they'll start bearing down. They will probably be feeling their baby move down in their pelvis. It's like very obvious that this baby is en route. Is sometimes they may be told, hey, you need to stop pushing. Like we need to check your cervix because we need to make sure that you're fully dilated because we don't want you to tear your cervix or we don't want you to swell your cervix. And then their response is, oh my God, my body is doing something wrong. So Roxanne, can you explain more what someone could do in that situation?
So in those situations, I normally tell someone if they're having this spontaneous urge to push, to let their body do what their body is doing, but do not add to the push. So you just breathe through them, let your body bear down, don't kind of tense up and prevent your body from pushing, but just allow it to. If you're not fully dilated, when you're doing these pushes, it's going to dilate and melt away your cervix, unless it is like you are 5 to 6 centimeters. But if you do a couple pushes and you feel no change, then maybe doing a cervical exam would be beneficial. But if you do a couple pushes because you're feeling that urge to push and you're allowing your body to do it, most of the time, the cervix is going to just melt away and fully dilate, and the baby will be born without needing a cervical exam, especially if you're seeing changes within the pushing progress. So you're seeing the perineum bulging, you're seeing the baby move down. Those are positive signs that pushing is progressing. If you're seeing none of those signs and you've been pushing for 30 minutes, maybe this is the time. Check the cervix. If it's not fully dilated, maybe it is. Baby's in a funny position, and that's why they're feeling that urge to push. And their body is trying to reposition that baby. But most of the time, and based off of research, there's not research that says you must wait until 10 centimeters to start pushing anytime. There's research that supports that just waiting for that spontaneous urge to push and allowing the body to push doesn't lead to these like cervical lacerations, like the cervix tearing open because it wasn't fully open, which is the concern about pushing before 10 centimeters, is that you're going to tear your cervix. The cervix is very vascular. It has lots of blood vessels. So if you tear it, this can lead to bleeding a lot. So it is like, if it does happen, it is concerning. We do have to like respond quickly in those cases. But I have seen one cervical laceration in my entire nursing career. And it was because the baby literally flew out of her body and she had like a little bit of cervix left. Of all of the people that have been at a birth center or the home births that I've been to where they had the urge to push and maybe their cervix wasn't fully dilated just yet, while they're pushing, you see the bloody show come out because the cervix is continuing to dilate and just melt away and the baby is born with no issues. And it's backed by research that this is a great option. So if you feel the urge to push, maybe don't add to it until maybe you know that that cervix is gone and if that makes you feel better. But if you feel the urge to push, allow your body to do what it's doing, especially if you're unmedicated, because it makes it so much harder mentally to stop to then restart back up again.
I also find that if you have the fetal ejection reflex, it's usually pretty quick.
Yeah. Like if that baby's not out within a couple minutes, like we should assess.
We should reassess. So yeah, I would say less than half an hour that baby is going to be out. Like that's being very generous with the time frame.
Some babies are larger, so like
the 3 of my births where I had the fetal ejection reflex was like less than 15 minutes from first birth, and I think my most recent one was like less than 5 minutes from first push, not first birth, first push.
15-minute pregnancy.
Yeah, from conception to birth now. So with the fetal ejection reflex, it's usually pretty quick. You're going to feel progress. You're going to be like, oh, yep, that baby is moving down. So if you're not feeling that progress and maybe we're at like 15, 20 minutes, I would probably do an assessment to see what's going on at that point. You don't really have to add to these because your body is doing it for you. But if you're like kind of nervous or like, I don't know if I'm ready to do this, just breathe with them. And your body's, again, there's really not a lot of effort on your part. Your body's doing most of the work. So let's talk about the Ferguson reflex then and how that is different than the fetal ejection reflex. So fetal ejection reflex, you're along for the ride. It doesn't really matter how high or low your baby is within the pelvis. It's because the fundus is super thick and it's like time to vacate premise.
Rocketing your baby out.
What is the Ferguson reflex?
So the Ferguson reflex is often confused with the FERS, and I think it's because the first three letters, like FERS and Ferguson, a lot of people get them confused because they also are similar, that they lead to an urge to push, where the Ferguson reflex leads to this urge to push, increase in oxytocin, but this is due to baby putting pressure on certain points in the pelvic floor after they've reached a certain station. So usually it's like +2 station. We're going to release a lot of oxytocin to get like that final rotation of baby through the bottom portion of the pelvis to be born, because that like final curve is a little bit harder. So by increasing the oxytocin that happens once that baby reaches that point, they're able to extend their head out and be born. But this is different than the FERS because this is just an urge to push. Like your body may still be bearing down without your control, but we usually still have to add to these pushes. But you're like, oh yes, I feel like I'm going to poop, or this baby is coming out at me now. I need to push. And it's usually like, oh, I need to push is common words that they'll say. And this is, again, because that baby has reached that level, it's just time to come out. And this is more commonly seen with epidurals, that they have an epidural, but all of a sudden they feel a certain change in pressure and they're like, I need to push. Like I feel constant pressure in my butt. I think the baby is low enough. And that's usually what I personally wait for, especially if someone has an epidural, is for that Ferguson reflex to hit and them to be like, I feel constant pressure, because that's their baby's ready to come out of their body. Versus FERS, you don't have to do anything. That baby is going to fly out of you. Ferguson, you usually have to add to it based off of where your baby is within your pelvis.
So do you think that the reason why you experience more of the Ferguson reflex with your labors is because there was a lot happening in your environment?
I mean,
both times?
probably both times. The first one was just like chaotic because this is our first unmedicated birth. I had no idea what was happening. I was just personally chaotic, and arriving at the hospital, 10 centimeters, water broke. But I also think that I felt the Ferguson reflex with my amniotic sac for both Joan and Lily. Their both births had bulging bags of amniotic fluid, whereas Colin's broke and he flew out afterwards. Whereas Joan and Lily, they're broke, and I still had to push a while. But I felt that urge because the amniotic sac was putting pressure on that Ferguson reflex area. But once it broke, I no longer had that urge anymore. So I just kind of had to like push until they hit that point, and then I hit the Ferguson reflex. But both of the times were chaotic, where Lily was just more chaotic because it's the first baby. We were getting there, and
you were drive-by baby.
Yeah, like it's just
drive-by birth.
Chaos for everyone. I don't think that there was a ton of people in the room or anything. I think there was maybe 3 or 4 people in the room, other than like my 70 support people. I had a lot of support.
It was pretty
people.
crowded in there.
But like employee-wise, like there was the nurse, the baby nurse, and then my midwife. And everyone else kind of hid behind the curtain and so I just weren't really there. Whereas with Joan's birth, there was a lot of people in the room aside from my support team.
It was also change of shift.
But there was change of shift. Like, so it was a little, and then it was also chaotic because I knew they don't prefer babies born in the tub. And I think that like got into my head when I started bearing down and Sarah was right there. I should have been like, I'm not pushing, Sarah. You can leave. I'm not bearing down. And could have just caught the baby with nobody in there.
So both of them are fairly similar to where it's probably going to result in a baby being born. The fetal ejection reflex, I think, is just like this baby is coming. You don't really have to do anything. It's just going to happen. While the Ferguson reflex, you might feel like an urge to push. And there might be some spontaneous bearing down with it, but you usually have to add a little bit more to it. Maybe a little bit more common if you have an epidural. So let's talk about epidurals now, because this is where we're going to have more of the should you push now, should you wait, because you're not really feeling your contractions. It's really different than an unmedicated birth where you feel every contraction. Like if I'm feeling contractions and you tell me I'm 10 centimeters, I'm just going to push my baby out. Like I'm not going to just keep hanging out here with contractions.
Laboring down is not an option for people who are unmedicated because they're like, I know.
No, I'm just going to push.
I'm good.
I'm just
not waiting an hour feeling these sensations. But it's a really great option if you have an epidural. Let's take a break from this episode to hear about our sponsor, Needed. Needed is a nutrition company focused on the perinatal timeframe that both Gina and I have utilized during our preconception, pregnancies, and postpartums. And this brand is someone we recommend to everyone that we know in this time period.
One of my favorite products from Needed that I use pretty much every day, sometimes multiple times a day, is their collagen. Needed's collagen has 15 grams of collagen, and so I love adding it to my coffee. I love adding it to my oatmeal because it provides 8 of the 9 amino acids that you need. Collagen is really beneficial to support your joint health, your skin health, your hair health. If I had my hair down, you would see how luscious and long it is, even at 6 months postpartum. Just don't look at Roxanne's hair. She just cut it all off.
It's thick, just short.
And it also really helps with tissue recovery, especially in the postpartum time frame, which is what I have found to be really beneficial for me. So if you want to check out Needed, check them out at thisisneeded.com. Know that Roxanne and I only recommend brands that we personally use and love. We don't just recommend whatever people pay us for. Like, we only recommend brands that we personally use. And Needed, very top of the list. You can use code MAMASTAYPOD to get 20% off your order. So there is some controversy with whether or not you should labor down based on some changes in guidance. And so we're going to break that down. But first, let's say, what is laboring down? Because you might be listening to this and like, so what does that mean? So what laboring down is if you have an epidural, because again, I'm medicated, you ain't waiting, and you're 10 centimeters, you can not push right away. And it really relates to how high or low the baby is within your pelvis. Some guidance says to wait 1 to 2 hours after you find out that you're 10 centimeters before you start pushing. Other guidance says you should start pushing immediately, regardless of baby's station or how high or low baby is within your pelvis, because there's risks to laboring down. And I think there is some nuance to it and some opportunity to have a conversation on what is beneficial, so that if this is something that you're interested in doing, you can have a conversation with your provider on how they manage it as well. Because if this is something that you're super interested in doing and your provider is totally against it, then we maybe want to have a conversation, and vice versa. If your provider is all for laboring down, maybe this is something that's concerning for you. So let's talk about how you labor down. What do you do? So you're 10 centimeters, so you have an epidural, and your provider, your nurse is like, cool, but your baby's kind of high in your pelvis. What station would you typically say, let's labor down?
Anything above +2.
Anything above +2. So I typically agree. Not just typically, I always agree.
She typically agrees
agree with
But there is some nuance, like you said, with laboring down. I normally won't, if someone is +2 station, I'm not going to offer laboring down immediately. I'm going to do a practice push with that person, which just means no one else. I have not called anybody, depending on their gestational, if this is their 5th baby, maybe I will call somebody. But this is when I just have them bear down with their contractions to see how much their baby moves. If their baby is +2 station and about to round the corner, they're going to move a lot with their push. And that's going to be we can labor down if you want, and your baby will just fall out in your bed. Or we can just bear down and your baby's going to probably be born in the next 30 minutes based on how they pushed. If they're +2 and that baby doesn't move at all, this is when I would be so we can wait a little bit, put you in a position if you need some time to ramp yourself up mentally that we're going to start pushing. So then usually I'll get stuff ready in the room, and they would labor down for 30 minutes while everybody gets into the room. And then they, again, still only push for a short period of time. But that's not my first option for someone who is +2 station. If someone is 0 station, I'll still always offer the practice push, but I always offer laboring down first. Because if you think about the stations of the pelvis, +2 station is pretty much the outlet. The baby's about to emerge
you can
from
see the baby.
pelvis. 0 station means the baby is in the middle of the pelvis, and that's the top of their presenting part, most likely the head. That is at the 0 station. So
how many centimeters is a station?
Generally 1 centimeter. But
so that's like
it's hard because all of our bodies are like slightly different. But
so it's like 5
generally,
centimeters versus
1
like 3
centimeter.
centimeters.
So like 1 nail bed is
Yeah.
like a station, kind of.
And so +5 station is baby is out of your body.
Like, yeah, baby is out of the body at
So
+5
if you
station.
think about it in that way, 0 station and +5 is 5 centimeters generally.
And you have to
And
like,
a +2 station to 5 centimeters where you can kind of see baby's head is 3 centimeters. That's a big difference.
Yeah.
That's a lot of time.
well, it's a lot of centimeters. And
And-
especially when you push, it's not just like, oh, I push my baby down, I push my baby down, I push my baby. Babies, it's like a pendulum. Baby comes down and then sucks back up. Baby goes down a little bit further and then comes back up. And it comes down a little bit further and then comes back up. So like your baby
It's just rocking
is rocking and rocking until it gets to the point at the bottom of, it's called the curve of Caris, the bottom portion of the pelvis, where they have to literally like turn and extend their head at that point. That is the hardest portion of the birth process, is getting them underneath that pubic bone, 2 + 2 station, pretty much. But until they get there, like, to just keep going back up in between.
I know, it's the
contractions.
worst.
And it's so if baby is 0 station, just like resting, that means that like you could push them down to +2, but then they're going to come back up to 0 station. So it's like it takes a while to go from 0 to staying at +2 because that is a pendulum, like going down and then they suck back up, going down and then they suck back up. So if you're 0 station and you start pushing, it's going to take a lot longer. And the act of pushing is very exhausting. But if we can labor down and allow your uterus, the fundus, to push the baby down, you do nothing but maybe nap for an hour, then you're going to be less exhausted. It may not take any shorter amount of time overall from 10 centimeters to birth, but exhaustion level wise, it's going to be a lot less and potentially less damage to the pelvic floor because you're not bearing down with everything you got onto your pelvic floor for long periods of time.
It's like the difference when you're pooping, when you like bear down to poop out versus like relax
Just
and
relaxing.
let your poop out.
Yeah.
That is much better for your pelvic floor. So let's look at the numbers then, because there are some studies on whether or not you should labor down right away when you're 10 centimeters or you should wait 1 to 2 hours. I will say any more than 1 to 2 hours is probably too much. Like if your baby does not move down within that time frame, you need to actively push because like that baby needs some effort.
And I think that that goes back to the difference between FERS and the Ferguson reflex. FERS, if your baby is like actively being pushed down without you having to add to it with an epidural, you likely have a little bit of a FERS reflex happening. And that's why laboring down is effective for you. But if you are the person that needs the Ferguson reflex to get your baby out, then you likely are going to need to push your baby until that +2 station when the Ferguson reflex is activated to then get the baby out of the final little bit.
So a Cochrane review in 2017 found that delaying pushing or laboring down decreased the duration of active pushing by 19 minutes. So this is your effort pushing, not just your 10 centimeters. It did, however, increase your length of the second stage of labor, which is from when you're 10 centimeters until your baby's born. So this is not talking about how long you were pushing for. Now, when we look at the overall second stage of labor, which is from 10 centimeters until baby is born. So this is not talking about the time that you were just resting and existing. This is just your cervix was 10 centimeters. And this is when they noticed that your cervix was 10 centimeters.
You could have been 10 centimeters longer.
And so in the 2008 randomized trial, the immediate pushing group had an average second stage of 102 minutes. So they found out that they were 10 centimeters and they started pushing from that moment until their baby was born. Took 102 minutes, which is
an hour and 42 minutes.
And then the labor down group pushed, or their second stage of labor was 134 minutes with a 60-minute delayed push. So they only pushed for like 74 minutes.
74 minutes.
Which is a lot less than the other group. But the difference between the second stage of labor was 32 minutes. So if you labor down, your second stage of labor will probably be longer because you're just sitting there for an hour or two. Well, yeah, no shit, it would be a little bit longer, but your active pushing phase is significantly less. And so then this comes with some conversation as well. So the longer your second stage of labor is, potentially the higher risk of postpartum hemorrhages, potentially the higher risk of infection is, especially if your water is broken. Or what are things that could increase that besides just being 10 centimeters and your baby's not born yet? Lots of active pushing pushing for a prolonged period of time could lead to maternal fatigue and exhaustion. Pushing is very tiring. It is not an easy thing to do. And so if you were actively pushing for 102 minutes, it may increase your risk of needing operative vaginal delivery, where like you are just so tired and you can't push anymore that your provider needs to give you a little bit of assistance to help the baby be born. So that could be a potential risk, which could increase some pelvic floor damage in that case if you start actively pushing right away. The next thing is, even though the second stage of labor is longer with laboring down, the active pushing phase is much shorter. And so you have to think about how much more effort is going on and which one of those is going to increase the risk of hemorrhage more. Is it just being in this second stage of labor longer, or is it actively pushing longer? And so that's where kind of the conversation I think needs to be is, okay, which of these risks and what is the actual risk? Like, what does that actually look like? It's still a fairly low number, but it is a little bit higher in the group that labored down versus the group that started actively pushing right away.
And it's only 30-minute difference between the actively immediately pushing versus laboring down. But you have to think about how many times are you going to push in a 30-minute period? And that is, you're pushing for 60 seconds every time you push. So that is a lot of effort. Go run 30 minutes. And then when I tell you that you need to run 30 more minutes, it's a lot. That's exhausting. 30 minutes is a long time. But in the grand scheme, when you look at that, it's like, 102 minutes versus 74 minutes. That doesn't seem like a huge difference. But 30 minutes is a lot of time, and it will feel like 70 years when you're the one pushing for 30 minutes longer.
It's also 30 more minutes where somebody probably has their fingers in your vagina as well, because I usually see a lot with like active pushing that the nurse or the provider, which can be really helpful. It can give you really good feedback. They're just like, what's the one with the cat with like the tongs?
Yeah, but that's like getting your pap smear, like what it feels like when you're getting your pap smear, which is how I feel when I get pap smears. But when you're pushing with an epidural, because it's, again, only really time you're going to labor down, you have an epidural, you likely don't feel shit. Don't feel anything.
No,
in
you
your
might
bottom.
feel shit. You might feel poop.
You might feel poop, but you don't feel pushes. Like, pushing is harder with an epidural because you don't have the same sensations. So we have to get creative with how we can get people to bear down and actually be bearing down in their pelvic floor and pushing their baby down versus just holding all of their breath in their chest and in their face. So doing internal feedback of when they're pushing, we feel the baby's head moving down, we feel your pelvic floor opening. This is going to give you more feedback of being like, okay, when I do this, this is what happens. So then you can start to create that mind-body connection with an epidural. With an epidural, also, the first hour of pushing for most people is just figuring out what the freak is happening within your body because, again, you're creating that mind-body connection. But when your fingers are inside of anybody's tissue for a long period of time, so 102 minutes versus 74 minutes, that's causing inflammation and trauma to the pelvic floor and to the tissues, increasing the risk of tearing and pelvic floor dysfunction. But it's either don't put your fingers in their vagina and then they push for 30 minutes, but they were all ineffective pushes and then trying to figure out all of these other ways and then they push for 4 hours, or putting your fingers in their vagina so that you can give them immediate feedback so that they can push more effectively and push for shorter. Risk benefits. So it's like
obviously
figuring out what works for them and doesn't work, because some people figure it out without anything. And then I'm literally just holding a warm compress on their bottom so they don't tear because they're like, I got this.
I think it's implied that this is not like you as the nurse making the decision. It is the person that is giving birth making the decision on whether or not they are going to have internal feedback. But I think it's a good conversation to have of, hey, can we see externally that you're doing that you're crushing this? Is it kind of hard for us to see? Are you feeling like you're being productive? Maybe we can do the internal feedback to see, but it should always be a conversation. But it's a tool that's available to you. And so let's talk about like when maybe somebody should or should not labor down and kind of like what kind of conversation should we be having? Because I've had it at times where my client, her health is starting to not look good. Like she's starting to get an infection. Like we have a fever, baby is looking like not too great. And so it's like, well, we don't want to labor down for 2 hours.
Yeah.
Like we want to see if we can try to like get this baby out. So that's usually a time where I'm like, hey, baby might still be a little bit high, but let's do a practice push. and see how it looks.
And that's why, I love practice pushes, and I will always offer them, even if your baby's 0 station, because some people can literally push their baby from 0 station to like crowning. And just some people their uteruses are very strong and they can do it. But there are cases where laboring down is not a viable option.
Especially if laboring down is relying on your uterus to push your baby out. If your uterus is starting to get infected, it's probably not going to.
Or you've just been in labor for a really long time. You haven't slept. You haven't eaten. Your uterus is a muscle. It's tired.
Yeah.
So laboring down is not going to be effective for everybody.
Yeah. So similar to the fetal ejection reflex, it's not 100%. It's not, hey, if you're unmedicated, you're 100% going to feel this. And it's the same with laboring down. It's not 100% of everybody who has an epidural should labor down if your baby has this station. We want to think about the different factors. So what conversations could we be having with our provider on fetal ejection reflex, on laboring down, and kind of exploring, how do I start pushing?
I think the first question would just be like, how do you manage pushing? Like when I start bearing down, how do you manage that? Because I also think your provider, going to be honest, unless you're birthing at home or in a birth center, you're probably not going to be there until your baby's crowning. It's just the case in the hospital is they don't call the provider until, some people say, until they see eyebrows. So it's really the nurses, honestly. So I would call the hospital, labor and delivery unit, if you're delivering in a hospital, and ask the nurses, what happens when I start to push? Because they will give you more of an idea of what will actually happen for pushing, because they are the ones that are there for most of it. So some hospitals will even have their labor and delivery nurses teach their childbirth education, and that will give you a better idea of how hospitals manage pushing. Because if the nurse, all they know is to do internal feedback, everyone's on their backs, as soon as they're 10 centimeters, they start pushing. That's going to be what they tell you over the phone. Like, oh, once you're 10 centimeters, we start bearing down and we can give you internal feedback if you have an epidural, and then you'll push your baby out on your back. And then the baby will be born when the provider is called when you're crowning. If they do more like shared decision making of like, we offer laboring down depending on if you got your epidural, these are things that they will tell you over the phone of how they manage pushing. Because your provider, unless, again, you're giving birth at home or at a birth center where your provider is going to be in your room more often, or if you're giving birth in a smaller community hospital where, again, your provider is more available to be in your room for longer periods of time, how they manage pushing is going to be when your baby is crowning, unless they have like very strong opinions against laboring down. But that's why calling labor and delivery, what happens when I start to feel the urge to push, with and without an epidural, they would be able to give you more of a feedback of what would happen during the pushing process. Asking your provider how they manage pushing. Like, once I'm 10 centimeters, what happens? And they'd be like, well, it would depend on baby's station, on whether or not I would recommend laboring down or not, or your nurses recommend laboring down or not, depending on baby's station. Or if they're like, once you're 10 centimeters, we just have you start pushing, that would also kind of help give you clues. But I always think like, I am obviously about to be a provider, so I'm about to be that person that shows up when you're crowning. But the nurses are so instrumental in the laboring process because they are there. They are the ones that are relaying what's happening during your labor. Like, they're the ones that are like, hey, something's a little off. You need to come assess her. So how do the nurses communicate with the providers and how do they manage things? Can be really helpful by just calling labor and delivery or attending a hospital class if it's taught by the labor and delivery nurses. But then asking the providers, like, how do you manage pushing, could also be helpful, because if they don't believe in laboring down, the nurses aren't going to labor down.
I think it could be helpful if they are against laboring down in all circumstances to ask why. Like, what in your experience has made you have this belief? Like, is it strictly based on ACOG guidance? Like, having the conversation, I think, is really helpful because it can be very informative to you as a patient as well. Of like, okay, this is how my provider approaches birth, and I don't want to say that their opinion is wrong by any means because it is backed by research as well. If they are anti-laboring down, but I think being able to approach every birth as a unique experience and understanding that there's nuances to them. Like, it's not labor down for everybody, nobody labor down, everyone's going to have this reflex. It's about exploring what is specifically happening in this individual birth experience and being open to exploring different avenues as needed.
With birth, it's very, very rarely ever black and white. Birth is gray, 100%. that anything could be right for one person and wrong for another person because we're individuals. We all birth differently. Obviously there's like averages for like how long people push for and how many people have FERS and who experiences Ferguson reflex and how long people push with laboring down without. But it's every person is different and will choose something different. So it's just about knowing the evidence and offering them their options, but still allowing them to choose it.
So hopefully this episode was informative to you. Roxanne and I were kind of going back and forth a lot on different conversations with the fetal ejection reflex, Ferguson reflex, laboring down or not laboring down. And so again, these are just options that are available to you. Some of them you can spontaneously choose. The fur you're not, it's just going to happen to you if it happens. Sorry. It can be really overwhelming. It'll be okay, even if it's kind of scary.
Some people
in the
love
moment.
It though, because again, they're like, as soon as it happens, I know
I'm
this baby's gonna rocket out of my body.
I know it's super intense in the moment, but I'm like, I would rather have that.
Yeah, it's not great pushing for
2.5 hours like I did with my first, where I felt nothing.
Yeah,
felt absolutely nothing. So these are all just options available to you, and hopefully it helps to facilitate more conversation with your provider so that you can build trust in the team that you have chosen to support you in your birth. If you want to learn more about pushing in general and childbirth education, check out our online childbirth education course because we offer what are your birth options, what is the labor timeline, what to expect during your labor experience, and we try to give you as much information as we can, fairly unbiased, because ultimately the best decision and the best choice is the one that you decide. It doesn't matter what Roxanne and I would do in the same situation or what we may recommend in that situation as a doula or a nurse / student midwife. It's about what you feel is best for you and your family, and we try to give you that information so that you can feel empowered to make the decisions that work best for you. So you can check out our online course at mamastayfit.com. You can bundle it with prenatal education. You can bundle it with pelvic floor prep and use code STORY10 to get 10% off any of our online offerings.
This podcast is sponsored by Need, a nutrition company focused on the perinatal time frame that both Gina and I have utilized during our pregnancies, postpartum, still to this day. We still love it. And you can check them out at thisisneeded.com and use code MAMASTAYPOD to get 20% off your first order.